been affected by an odd post-encephalitic syndrome. They had contracted influenza during the great epidemic of 1917-18. And then sometimes years later, they fell into a Parkinsonian, almost catatonic state. Many of them hadn't moved or spoken for years. And then in the 60s, the drug L-Dopa became available, and they were animated like Pinocchio. Some of them began speaking, walking, even dancing and singing. So he did the expected thing that an ambitious young doctor might do in that circumstance. He wrote some case reports. He submitted them to the British Medical Journal and JAMA, places like that. But he wasn't very happy with what he'd written. It didn't seem to quite get at the truth of what he'd seen. So this young neurologist, who was a British expat named Oliver Sacks, decided that he would write not only case reports, but what he called biographies of these patients, in which he would interest himself not only with their rigidity and their masked faces, but with the lives into which this extraordinary illness had intruded. He pulled these together in a book that was called Awakenings. It's recently been reissued. Some of you may have seen the movie based on it. And here is just a little taste of what one of these biographies sounded like. It's the story of Aaron E. Mr. E was born in 1907, the elder of fraternal twins. His parents had immigrated to the States a few years before, and at the time of Mr. E's birth had established a flourishing delicatessen business in the right part of Brooklyn. Mr. E's early life was one of work, seriousness, and laborious self-improvement, delivering newspapers and half a dozen other jobs as a boy and adolescent, and supplementing his education with night classes, public lectures, and long hours at the Brooklyn Public Library. By the age of 23, Mr. E had established himself as an up-and-coming accountant and was able to marry and take out a mortgage. Over the next 30 years, Mr. E showed exceptional vigor and enterprise and was able to expand into a 6-man corporation. During these years, he enjoyed excellent health. He was a Freemason, a prominent member of the local synagogue, and vice president of the local school board. He had a very large circle of friends and business acquaintances, went to theater every Thursday, played golf every Sunday, and went on a camping trip to the Adirondacks with his wife and 5 children every summer. He was the epitome of the self-made man, the American success story. It is probable in retrospect that the first symptom of Parkinson's disease showed itself during a trip to the mountains during situations of unusual exertion. Now, I think I'm preaching to the choir when I suggest that medicine would be greatly enhanced for both practitioner and patient if every patient chart sounded like this. More empathy, more understanding, less of what we saw in the dramatic reading. Probably even fewer tests ordered. But you'll object, that's very unrealistic, isn't it? I mean, after all, very few of us have the talent of an Oliver Sacks. And even if we did, we don't have the time. And even if we had the talent and the time, who's going to pay us for it? I mean, you know, how do you bill for literary nonfiction? What's the DRG for that? And yet, Let's daydream a little. What if more of us as clinicians were writing like this? What if we were using the study of such texts and the writing of such texts to sharpen our students' interpretive powers? What if, pie in the sky here, what if there was even a new discipline of medicine devoted to a study of how it is we interpret meaning? We could call it something like narrative medicine. Well, of course, we don't have to daydream about these things. They all exist. What we can daydream about, what I daydream about, is more of all of these. So, what I'd like to do is, with two of my colleagues, offer a little smorgasbord sampling of ways in which those of us who are both physicians and writers bring literature into our practice and teaching. I'll be talking in the midsection here about being a physician nonfiction writer. We'll first hear from Susan Porres, a surgeon at Mount Auburn Hospital, about her work with medical students. And then we'll wrap it up with Goyo Abel, an oncologist at the Dana-Farber, who will read some of his poetry, and then hopefully have a little time before lunch to take some comments and questions. Dr. Porres.
Thank you, Suzanne, and thanks to everyone who helped arrange this wonderful day. I became involved with medical student education and writing as a tutor in Patient Doctor 3 course, which was a small group session course designed to help third-year clerks adjust to the transition from classroom to bedside. And at that time, when students were given their writing assignments, I was struck by the power of their writing and the importance of their observations and experiences. And out of this grew a collection of essays, which we published as The Soul of a Doctor. One of the criticisms of our book has been that there's snippets of experiences with patients, and that you meet the patient, find out their problem, they make their point, but you never get to see what happens. And this is actually a criticism of medical education as well. We've often had brief encounters with patients and short rotations through multiple institutions. And you might know that Harvard Medical School, in response to this, has moved to a longitudinal experience for third-year clerks, having them get their experience at one hospital for an entire year. But even earlier, at the first-year level, in the mentored clinical casebook project, students that want to can be assigned a patient and a mentor for the year and follow them. And out of this, they write a casebook to describe their experiences. So I wanted to read to you from one of these. We're in the process now, myself and several students, of compiling some of these very amazing casebooks into another book for publication. And this is Mother's Day by Ariel Wagner. I begin the course filled with excitement and naivete. Though I have no idea who my patient will be, I imagine us forming an instant bond. The relationship will imbue my otherwise dry basic science courses with purpose, I tell myself. I will take the time to listen and reflect, and I will become a better scribe for the patient experience. Even without knowing my patient, I know it will be perfect. It never occurs to me that it could be otherwise. The first time I hear of Nadal, he is 12 years old and described to me as vegetative. I jot this down on a Post-it note, along with his numerous other diagnoses. When I meet him in the hospital, he lies prostrate in his hospital bed, eyes open but not seeing, his occasional movements without purpose or merely reflexive. He's been like this for a long time, perhaps always. I'm overwhelmed, not so much by sadness or pity at the sight of a 12-year-old in this state, but a sense of bewilderment as to the purpose of all of this. What kind of life is this? Why work so hard to prolong a life that seems indifferent to the world or in a state of potentially constant suffering? The answer to these questions depends on whether you see Nidal as someone with an inner life who knows the world in some way, or whether you see him as vegetative. His mother, Sabira, believes he can sense and feel. I know his brain works, she tells me. He has life in him, but people don't see it. She'll tell you he likes a little juice on his tongue, or the Finding Nemo movie playing on the flat screen above his bed. She speaks to him and believes that on some level he understands. And even the doctor admitted that Nidal's responses appeared to be a higher level than reflexive. In particular, his utterances or vocalizations and smiles. These interpersonal expressions suggest that he does, at least at times, experience a level of consciousness. As I try to understand his experience, I realize I'm really trying to understand his mother's attachment to him. At the end of the day, it doesn't matter whether Nidal fits this or that criteria. Truth is in the eye of the beholder, and all that really matters is what's true for Sabira, because she's Nidal's mother and the one who takes care of him. Following his birth, Nidal's doctors noted his head was quite small. It was smaller than most newborns. This didn't seem too concerning at the time because as a preemie, his whole body was small. Indeed, he was smaller than most newborns by length and weight as well. But by 5 months, his head had barely grown, dropping him down to the bottom 2% of infants in his age group. His head was no longer proportional to his body size, and his doctors began to refer to him as microcephalic, which is almost always associated with a developmental delay. Despite his brain's lagging growth, he did seem to make some progress developmentally. At 5 months, his neurologist indicated he was alert and active on examination. He could coo and make other vowel sounds and bring his hands to his mouth. And by his mother's account, he could recognize his parents and brother, although it's hard to know if this was truly the case. The neurologist noted that Nidal could only fix his gaze on an object occasionally, and his eye movements seemed random. He could grasp objects, but not for any prolonged period of time. How concerning these signs were considered is not mentioned in the note, but even so, the picture seemed to be one of some progress. Reading through these early notes, I start to picture Nidal a little better. I see him as a newborn, reaching and smiling, see him fix his eyes on his mother just long enough to tell her he knows her. I imagine his mother's hopes as Nidal's condition stabilizes and she takes him home. I imagine how in many moments he seemed like any other newborn. The hopefulness is overshadowed, however, by the knowledge of what is to come. Eventually, the markers of progress disappear. He can't crawl or sit up. His vision worsens and he's determined to be blind. His seizures continue despite medication. And by the time I reach for his files for early childhood, any neurological development that once existed appears to have halted. Given all the difficulties Nidal faced as a child, I asked Sabira if the doctor spoke to her about a DNR, do not resuscitate order. And she answers the question with emphasis. We want everything, she tells me. Hoping to push her further, I ask her if she always felt supported in this decision by the doctors and nurses. She pauses, thinking it over. I don't know if everyone supports it, but no one's ever been disrespectful. I'm heartened and somewhat surprised to hear this. And after thinking about the question longer, memories of caretakers who didn't see things her way return. She recalls an occasion when the nurses referred to Nidal as comatose after hospitalization at Children's. They didn't see him as a viable human being, she tells me. They saw him as someone we were wasting good time and energy on that could have gone to other children. And this statement resonates with me because it articulates my own sentiments on first meeting Nidal. I have whole journal entries devoted to this single thought. No matter how hard I try to empathize and understand, I always come back to it. An almost incomprehensible amount of energy and resources wasted on a child who couldn't benefit. It seemed absurd and unfair. One afternoon, while waiting for Sabira, I find myself alone with Nidal in his hospital room. I attempt to reconcile my views on the resources and energy spent on him with those of his mother. As I sit there, I stare at him, trying to read his face, his body. I try to feel some connection to him, something to make me understand his mother's affection, something to make me feel allied with him as my patient. That he can't respond doesn't make him that different from many other children I've cared for and that I have felt connected to. Infants are unaware of themselves and unable to communicate except by crying, and yet I also often felt an instant attachment to the infants I worked with in Mali. But I failed to develop a similar affinity for Nidal. I don't know why it doesn't come, so I just sit there, I watch him, I reflect, I wait for a connection. When I look at Nidal, there are a lot of things I think I'm supposed to feel: sadness, affection, sympathy. But more than any of these things, I feel angry. I spent 2 years as a Peace Corps volunteer in Mali watching children die. I used to keep a journal, not the usual sort of thing where you write about your day and your feelings. It was a journal of dead children. Determined not to forget them, I wrote their names, descriptions of who they were, how I knew them, why I loved them. Immersed in a culture in which it was unacceptable to show emotion, I poured my pain into my entries. As helpless as I felt, I told myself some way, somehow, I would do something to change this. No matter how much I cared or how hard I worked, the entries piled up. Malaria, malnutrition, diarrhea, simple diseases, cheap deaths. The contrast between the two realities is so stark, I have a hard time moving past it, and sometimes when I get home from visiting Nidal, all I can do is cry. The last time I meet with Sabira before completing my casebook, she tells me she can't imagine her life without Nidal. She never had any doubt about keeping him when she was pregnant, and she certainly doesn't have any doubt now. In my meetings with her, I get an occasional glimpse of what her life was like before his birth. She worked as a science teacher in Boston, and she tells great stories about her students and the stunts they pulled in class. She was happily married. Her pregnancy in particular sounds like a happy time. She smiles as she remembers how excited her other son, Afia, was to be having a baby brother. But things changed once Nidal was born. His father couldn't accept his condition, believing it to be a curse. He was devastated, she tells me. But what devastated her was that he could be disappointed by what God gave them. In her understanding of Islam, any child was a gift. God gave me this child, she tells me. This is my gift, and I will do all I can to make him happy. But the Islam her husband knew taught him that disability was a form of punishment from God. Their views were not easily reconciled, and not surprisingly, the toll on their marriage was significant. He's deaf. He's blind. He can't feel anything, he once shouted at her. He should die. Although Sabira doesn't let her emotions show, as she repeats these words, there's no escaping the pain they must have inflicted. The words cut like a knife. I play them over and over again in my mind, trying to imagine what it must have been like for her, loving her child as she does, to hear these words from her own husband. Is there value in a life like Nidal's? 6 months ago, I might have answered no, but today my response is different. There is value in his life, not so much for himself, because there's no evidence he's aware of himself or the world around him, but for others. For one, there are the countless doctors, nurses, residents, and medical students like myself who have learned at his bedside. He's a physiology textbook, Dr. Bahir told me when she introduced us. There's nothing you can learn about the human body that Nidal can't teach you. And there are the other disabled children and their families who benefit from Sabira's advice and example. She has become an advocate not only for her own son, but for disabled children in general. Through her Team Nidal Facebook page, she shares information about his condition and her experience caring for him, not to mention an assortment of medical articles, prayers, and motivational thoughts she thinks may be of interest to other parents. Many who visit the site write to her for advice or thank her for her words. Just one indication of the impact she's had on the lives of others, an impact only possible through Nidal's inspiration. Perhaps more important than any of this is the role Nidal plays in his mother's life. While those on the outside may look at the two of them and be overwhelmed by the burden and sacrifices required by his care, this is not what Sabira sees. To her, Nidal is a source of happiness and love. He provides her life with meaning. And what is more valuable than that? Thanks.
Wow. So once a month at my hospital, Mass General, and hospitals around the state, there's a literature and medicine discussion group sponsored by Mass Humanities. They kick in for a little dinner and to pay a little stipend to the facilitator, who at Mass General is me. At the Brigham, it's our faculty member here, Amy Shipp, and at the Dana-Farber, it's our poet you'll hear from next, Goyo Abel. You might ask, why bother? What do you need the literature for? Why not just have staff get together and drink a little wine and blow off some steam? That sounds nice too, but what the literature provides, I think, and I've been doing this several years now, is a conduit for difficult conversation. Through the text, a poem, a short story, a memoir, doctors, nurses, nurse practitioners, administrators are able to talk about things such as what it feels like to feel inadequate, what it feels like to dislike a patient. A difficult conversation we had a few months ago centered around some memoirs we read by nurses. And as we were talking, we got down to the question of what is a nurse? And how is a nurse different from a doctor? It was a complicated and difficult conversation, and one I thought about a lot. So I took Flannery O'Connor's advice, and I kept writing until I understood better what I thought. And so I wrote a column about this in the Boston Globe, and this is what I wrote. When I was 8 years old, I had an emergency appendectomy in a small county hospital near the summer camp I attended. I have a vague memory of the camp doctor who examined me briefly and decided I needed surgery, and no memory at all of the doctor who performed the operation. I do remember in detail, decades later, the camp nurse who sat by my bedside until the doctor arrived, and the nurses on the children's ward who brought me 7-Up with a bendy straw and checked my incision and told me I would be okay. I thought of that long ago summer just recently after a session of the literature and medicine group at my hospital. This particular night, we'd been discussing narratives by two nurses from very different eras. Louisa May Alcott's Hospital Sketches, 1863, and Mary Jane Nealon's Beautiful Unbroken, 2011. A question came up as we considered Alcott's account of caring for the Civil War wounded and Nealon's descriptions of treating the homeless and those infected with HIV in the 80s and 90s. What's the difference between a doctor and a nurse? I should mention, by the way, it's National Nurses Week, in case you didn't know. 50 years ago, this question would have been easy to answer. With few exceptions, nurses were women and doctors men. Doctors had many more years of education than nurses. Nurses had a more physically intimate relationship with patients, providing enemas, baths, and back rubs, while doctors moved from bed to bed, touching patients only as necessary to make a diagnosis or to assess a patient's progress. Nowadays, while more than 90% of nurses in the U.S. are women, more than half of the entering class of some medical schools are also women. Nurses are more likely than ever to earn bachelor's degrees or master's or PhDs, and enemas and baths are delegated to assistants. Today, that 7-Up would have been handed to me by a food service worker, and nobody gives back rubs anymore. And yet, our group still felt that there was a fundamental difference between doctors and nurses. One is true today as it was when Alcott was dressing cannon wounds among Union soldiers, and that it has something to do with time, and even more to do with a clinician's relationship with a patient. In the hospital, this difference is easier to identify than in a clinic or office practice. Nurses work set shifts, 8, 10, or 12 hours, and are assigned specific patients whom they see frequently during that period. Doctors, on the other hand, visit the patient once, maybe twice a day, usually for a few minutes, and with a team of other doctors and medical students. Doctors also show up when something goes terribly wrong: respiratory distress, high fever, a drop in blood pressure. When a patient rings the call bell because they can't sleep, or they're in pain or frightened, it's the nurse who appears. In the hospital, doctors make important but relatively few decisions, including which medication a patient receives and when they'll be discharged. Nurses make dozens of decisions that come up every shift about every possible aspect of a patient's care, whether a patient's condition is deteriorating, whether to administer an as-needed medication, and when to evict a disruptive visitor. As I learned after my appendectomy and relearned years later when various family members were hospitalized, nurses spend more time with patients and address much more closely than doctors do a patient's actual experience of illness. In the hospital, doctors deal in critical, but for the patient, relatively abstract issues. The idea that a patient has a particular infection and needs a certain antibiotic is formulated by the doctor, but the nurse plunges the drug into the patient's veins and monitors the breaking of the fever. In an outpatient practice such as mine, the distinction between doctors' and nurses' roles can be more subtle. Nurse practitioners prescribe medication, perform physical exams, and act in many ways indistinguishable from doctors. Outpatient RNs, such as those with whom I work, may find themselves on the phone with patients all day long doing triage, while doctors have more actual physical contact with patients. And yet, even when the traditional roles seem to be at least partially reversed, I see a clear distinction between the nurse and the doctor. Not long ago, a patient of mine who takes anticoagulants saw blood in his urine. It's an upsetting symptom, one that raised several disturbing questions for the patient. When would the bleeding stop? What did it mean? Did he really need to be on these potentially dangerous drugs? Did anybody care that he was bleeding? The nurse with whom I work talked him through these concerns, and any nurse will tell you this is part of the job, calmly listened to him express the fear and anger he wouldn't reveal so readily to his doctor. By the time I saw him, the patient still had questions, but he didn't feel quite as upset as he had before speaking with the nurse. She had acted as the intermediary between his experience, bleeding, frustration, and my agenda, his need for anticoagulation. Perhaps this is as good a description as any of what a nurse does. One of the nurse practitioners in our literature group offered a slightly different one. She was struck years ago while working in the emergency room that when a foul smell wafted from one of the patient's rooms. The doctors scurried past it, while the nurses threw aside the curtain and rushed in.
I'm very pleased to be here today to read some of my poetry. When Suzanne and Susan and I got together and we decided that I would read some of my own work, to be honest, I was anxious about it because I tend not to write about patients. And I said, well, I'm not sure people will be very interested in this, but it was actually an excellent exercise because I went over my own body of work, including my MFA thesis, and found that medicine was everywhere in my writing. And in many different ways, both informing the writing and in some poems that I'll show you, actually the reverse, where the poetry informed what I do as a hematologic oncologist. I was lucky during my MFA to study with Rafael Campo, and one of the things that I had done, and I forgot I had done this, was come up with a list of words that I felt had a lot of meaning in medicine and that might also be interesting in a poetic context. Some of the words like failure to thrive, found down, alpha blocker, negative pressure isolation, unopposed sympathetic drive. These are all words that we use in medicine a lot, but actually have a second meaning outside of medicine. Even one this morning in the play, the fellow was talking about contact inhibition. That's a great term for poetry. And so the first one I'm going to read to you is called Hierarchy, and one of those terms shows up in this. Hierarchy. To clear the neck of a victim of trauma, a doctor simply asks, "Does this hurt?" while pressing upon it. If the victim says no, he may come out of the collar placed at the accident scene, but only if he is not injured somewhere else. After all, the victim cannot sense that his neck is broken if his legs have been severed as well. They are a distracting injury. He is unable to feel pain in the context of greater pain. And that term, distracting injury, actually became the title of my thesis, because I think that's a great idea to explore outside of medicine. Most poets at some point are encouraged to write an ars poetica, which translates roughly to the nature of poetry, and it is your relationship with poetry, what it means to you. Archibald MacLeish wrote a famous one where there's the line, "A poem should not mean but be." And for me, poetry is often about the process of editing, which is what I also do in my other life with papers and grants. And as a hematologic oncologist, it was interesting for me to find my ars poetica and see that there was a lot of blood in it. So here it is, ars poetica. I heard the shrill buzz of a mosquito, so smashed it. Having recently stung, it was languid, lousy with blood. I felt burgundy liquid on my fingers, probably my own. I rubbed them together and raised them to my nose, smelling acridity, shades of yeast. It turned into a paste, thickened with bits of eyes, wings, and legs. I could tell there was a lesson there, but like the fleeting wine that had made me kill, the window of understanding quickly closed, almost, held just ajar by a decreasingly wooden piece of poem. The next way that I found some medicine in my writing was there's specific, I was surprised again to see this, but poems that I had used disease processes as metaphors for emotional processes. So I had a poem called Emotional Diabetes, which referenced the lability of a partner at the time who had sugary highs and unresponsive lows, both of which were dangerous and needed intervention. The next poem I'm going to read for you is called Moya Moya, and this is a cerebrovascular disease where there's a narrowing of the arteries in the circle of Willis, and a lot of collateral circulation happens. And if you ever see this on CT scan, it's actually quite beautiful, but the small vessels that develop are much more prone to bleeding and clots. So this is moya moya. Blocked or constricted, we found our way around that high-pressure circle. Smoke-like in the way of Arabic script, we moved out from its crimson center. It almost seemed beautiful. We even felt a little better. But it was just temporary, made of much weaker stuff. And then I found a few poems that really were kind of the reverse of being informed by medicine, but I saw were perhaps poetry informing my medicine. As an oncologist, I have a lot of patients who end up dying, have to deal with death a lot, and also patients who have to make decisions about how much, like in the play, to keep fighting, how much toxicity to take with the hope of living longer. And so there's a big tension between harm and life. And I found this poem that I had written actually when I was in the first few years of being an independent attending. And it's called Aptitude. Aptitude. My grandfather worked fast when deadheading geraniums. In a matter of minutes, he'd attend to all of the overwintering specimens scattered around his seaside house. Flash assessments were followed by a squall of wrinkled blooms, papery leaves, and spent crane's bills. His warm furrier's hands would become a liver-spotted machine, anchored on one side by a ram's head pinky ring, on the other by a medicinal copper bracelet. I would watch him anxiously. Even then, I grieved for the green bits that had been mistakenly sacrificed, still living for the promise of more life. And then the other part that came up a little bit in my writing, in our literature and medicine class, I actually make sure that we have one class that's about not medicine as much as academic medicine and publishing and the sort of high-pressured world that we work in outside of patients. It's a tough thing to be on the track and promotion track and deal with the stresses of that. And I think we often develop what I call the suspicion of optimism, if you're an oncologist on one side and then an academic researcher on the other. And it's important to have, in your personal life, some balance and people that can reinvigorate your belief and your faith and optimism. And I'm lucky to have a partner who does that. This last poem is called Increments. Increments. I'm sorry I doubted it, and you were right. It was partially because I'm prone to do so when you tell me things. But it was also because I knew that if it turned out to be true, that daylilies only bloom for one day, this would add to my sense of despair about their over-large green stalk growing. Although now I can guess what you'd say next, that one day of tawny beauty is so much better than none. Thank you.
I don't know how I'm going to make it through the afternoon. My heart is already up to here. Can we take just a few comments and questions, please, for any of us? Sir.
I applaud all the initiatives that narrative medicine is making, and I just wanted to make a comment that at Columbia University in the city, there's going to be an international conference on narrative medicine at Guy's Hospital in London with King's College Guy's Hospital and Columbia coordinating that. And one of the things that I think people should think about is how narrative medicine, as well as music therapy and dance therapy, can be embedded not only, and everybody in this room understands this, not only to help our patients, but how can this be discussed at the level of national healthcare policy? How can music therapy, dance therapy, and even concepts like open notes and narrative medicine be understood by payors as being essential for the future of healthcare. And I think all of us as physicians have an obligation to bring this message to Washington and to make sure that this happens in the next 10, 15 years, if not next year, that this is going to happen as part of national healthcare policy. Thank you.
Thanks for that comment. That's great.
Hi, my name is Jennifer Scott. I work as an obstetrician gynecologist at Beth Israel and at Brigham. And I've been talking about this with some colleagues, but I think with electronic medical records and open note or a patient site, that we have the opportunity to get patients to contribute to their own narratives as we take care of them. Whether we could capture resilience factors that they might perceive that they have, or other parts of their history that we may miss in our history taking. So I would be open to people who might be interested in collaborating on a project such as that.
More lunchtime talk.
Hello, my name is Jamil Ludd, and I am a part-time caretaker of a patient who passed away last year. And my field is in videography. And I got into videography as a form of therapy. You know, what I find is similar to dance, writing. I consider myself a visual writer. And I guess my question would be, my question would be, as a writer, what do you think about visual writing, you know, as a form of expression or a form of talk about your patients or your experience? And is that something that you guys would even consider worth sharing?
Mm-hmm. Yeah, I'm a huge fan of documentaries. There have been a number of both professional and amateur documentaries in which patients narrate their own illnesses. In fact, if you look at the Well blog in the New York Times, there's a particularly moving one going on right now by a newlywed young woman who is being treated for cancer. But yeah, thanks for bringing up the. I think of video documentary as really as an extension of that kind of narrative writing. It's great.
There's a program at Penn State Hershey with clinical medical students where they give them video cameras and they have them videotape encounters with patients, interview patients, or one patient over time, and then they go through the process of editing to create that narrative arc, to tell a story that's meaningful, and then they have a video slam where they share these with each other, and apparently it's incredibly powerful. Are there other?
I just want to make a real comment to your comment or question. So when they were doing that dramatic reading, I was actually thinking about the film version where Emma Thompson played that role, and it's just profound. So I personally feel that any kind of film version or video version of these depictions are really powerful and moving.
I think there was one or two over in that corner.
For a number. Is this on? Okay. For a number of years, I've taught in Patient Doctor 1, and John Stokel mentored me in narrative medicine, really, and in videotaping the interviews by the first-year medical students with the patients, then going back to the classroom. This is not the kind of mock patients that we do in the exams, but rather live patients. And I don't know of a more powerful way to teach narrative medicine than that. And the just one quick piece of it is when students laugh at the mistakes of other students, they can do that. We can't because they've made similar mistakes. And so there's huge learning that goes on in that process. But there's many more examples of that. Sure.
Is there someone else over here? Any other comments before we move on to lunch?
Thank you so much, everyone. We now have
a chance to really sort of stretch ourselves, to share with each other and all the stories that have been building up inside of us for the last 3 hours, share them with others. I just want to call your attention to the form that's in the personalized form that's in your folders. That has the gallery assignments and workshop assignments for the afternoon, but on the top of the paper it will also say either Barker or Bush. And those are the two spaces in which we're serving lunch, and there will be a lot of sharing and a little bit of music. The Barker Center for the Humanities is a beautiful space that is near the faculty club, and so if you look for signs like this and volunteers, they will point you in that direction. So when you leave the Sackler, take a left. If you're going to the Bush Hall, when you leave the Sackler, take a right, and it's across from Sanders Theater. And we will reconvene at 1:30 when we'll have about half an hour talking about what's to come, and then we'll all break for our workshop and gallery experiences, and then come back and share again. Thank you.